I'd like to welcome everyone to AHRQ, National Web Conference on the Role of Health IT to Improve Care Transitions. Although a few people are still logging in, we're going to go ahead and get started on time. My name is Commander Derek Wyatt, and I will be moderating this webinar. I currently serve as the Division of Health IT Research Grants Manager and the Center for Evidence and Practice Improvement at AHRQ. This slide shows the agenda for today's webinar. Please also note that we are recording this webinar, and the recording will be available via the AHRQ Health IT YouTube channel in about 2 weeks. Also, copies of the PowerPoint slides will be sent to participants via email following the webinar. We are pleased to have with us today an esteemed group of presenters. They include Dr. Anuj K. Dalal, Brigham and Women's Hospital and Harvard Medical School, Dr. David T. Liss, Northwestern University, and Dr. Sharon Hewner, State University of New York at Buffalo. This webinar event is accredited by Affinity CE. And for those of you who are interested in receiving continuing education credit for participating in this activity, information about how to claim your credit will be presented at the end of the presentations. It will also be emailed to you after this webinar. For the purposes of accreditation, let me note that AHRQ, TISTA, Affinity CE, and the presenters do not have any financial interest to disclose. Lastly, please note that no commercial support was received for the development of this learning activity. Just a brief note about questions. We have reserved time at the end of the presentations to address participant questions. However, during the presentations, feel free to submit questions that you have for the presenters using the Q&A panel located on the right of the PowerPoint slides. As a reminder, participants are in listen-only mode, so ask questions, or to be able to ask questions, you will need to use the Q&A panel. This slide shows the learning objectives for today's webinar. By the end of this presentation, you should be able to describe the role of health IT in improving health outcomes during care transitions for patients with complex conditions. Describe how mHealth technology can be used to improve care coordination and transitions. Identify barriers and facilitators of implementation, adoption, and the use of patient-centered discharge toolkit. Discuss the use of clinical decision support tools to improve the quality of transitions for adults with multiple chronic diseases. And now it is my pleasure to introduce our first presenter, Dr. Anuj Dalal. Dr. Dalal is an associate physician with the Division of General Medicine at Brigham Health and Associate Director of Harvard Brigham's Research Fellowship in Hospital Medicine. He is also an assistant professor at the Harvard Medical School. His work focuses on use of health IT to improve management of test results, patient-centered communication, and patient engagement in acute care and transitional settings. His most notable projects include an automated notification system for results of tests pending at discharge, a patient-centered microblog messaging platform to improve fragmented care team communication, and an acute care patient portal to facilitate patient self-education and patient-provided communication. Currently, he is piloting interactive patient-centered tools to engage patient in discharge preparation and to facilitate real-time communication with providers during hospitalization and after discharge. And now, allow me to turn the controls over to Dr. Dalal. Dr. Dalal, make sure you're not on mute.
Thank you, Commander Wyatt, and I thank you for the opportunity to present on AHRQ's webinar. As Commander Wyatt was saying, my name is Anuj Dalal, and I work on digital health innovation at Brigham Health. And today it's my pleasure to present to you some of the preliminary results of our AHRQ-funded grant, Interactive Patient-Centered Discharge Toolkit to promote self-management during transitions. So we have three learning objectives. The first one is to describe the design and development considerations for the project. Number two, to identify barriers and facilitators to implementation, adoption, and use of the patient discharge tools in clinical practice. And number three, to discuss potential impact of the patient discharge tools on key patient outcomes. So the transitions from the hospital can be unsafe, resource intensive, and associated with poor experience. The discharge process, as we know, is often initiated late during the hospitalization. And suboptimal discharge preparation can lead to delays, stress for clinicians, dissatisfaction among patients, as well as their caregivers. Incorporating patient and caregiver reported concerns about their discharge preparedness through use of standardized checklists, in fact, could facilitate more proactive identification of concerns prior to discharge. However, this has not made its way into clinical practice. So the project goals, as part of our AHRQ-funded, our AHRQ-21, we aim to do the following. Number one, to facilitate proactive discharge preparation by administering a 16-item electronic discharge checklist, as well as a web-based video to patients or their caregivers approximately 24 hours prior to their expected discharge date, or EDD. Display patient-reported concerns from the checklist on a clinician-patient safety dashboard that we integrated into our EHR, and our EHR was Epic, so that clinicians could see these patient-reported concerns from the checklist in real time. And third, to provide patients or the caregivers the option of requesting secure post-discharge text messaging with their discharging attending or senior clinician. With regard to the methods, when we assessed the climate at our institution, we went out and we engaged institutional stakeholders to ensure that the intervention components align with organizational priorities. So these are things like identifying discharge barriers, improving accuracy of expected discharge date entry, enhancing the patient experience, reducing costs, as well, such as decreasing length of stay, as well as readmissions. During implementation, we measured quantitative patient and clinician usage data and type and frequency of patient-reported discharge concerns. We also conducted interviews and observations, analyzed the feedback from patients, as well as the clinical staff who were involved in the pilot. And we used a two-person consensus approach to identify key implementation barriers, as well as strategies to promote adoption. During evaluation, we basically conducted a pre-post study to assess the impact of the intervention on key clinical outcomes. And this included the 13-item patient activation measure. And we also looked at post-discharge healthcare resource utilization from within our healthcare network, as well as reported by the patient through a 30-day phone call. So these are things like urgent care use, emergency room visits, as well as hospital readmissions. So I'd like to give you an overview of the digital health intervention, the Patient-Centered Discharge Toolkit, or PDTK. To give you a background, we were concurrently developing infrastructure that was integrated into Epic, and that included these three tools. Some of them were patient-facing, and some of them were clinician-facing. So we had mobile tools, including an acute care patient portal that you see on your left. And then we also were developing and had integrated into Epic a safety dashboard that obtained data from Epic in real time through the use of web services. And then we use our developed logic to identify and flag patients who are at risk with a red flag, patients who are guideline compliant with the green flag, and then patients who are at risk who didn't need any intervention with a yellow flag. So this infrastructure was in place. There was also a bedside display that would allow both patients and as well as the members of the care team, a nurse and the clinician, to look at key items about specific risks. So if a patient wore glasses, if a patient had a latex allergy, if the patient was at risk for falls. And so what we did is, this infrastructure, what we did is we built for the PDTK components, what we did is we basically enhanced this infrastructure by doing the following. So on the mobile tools, we added the discharge checklist as a module into the patient portal, and we also developed a prototype of the discharge checklist in REDCap, which was available on mobile devices. On the bedside display, we posted the patient's expected discharge date that would automatically update when it was changed in Epic, and that was also displayed on the patient portal. And then on the dashboard, we added this discharge column, and this discharge column would give information about the expected discharge date, as well as barriers to discharge that were entered in Epic, and then would also have information about the checklist that the patient entered from REDCap, the mobile REDCap version, or the patient portal. It would update the dashboard and display this icon. And so about 24 hours prior to the expected discharge date, basically our research assistants would go up to the floors, talk to the nurse, and approach patients and encourage them to complete this checklist and view a video. And then the clinicians would be notified in real time within the EHR through this dashboard. So this is, I'm going to just provide an overview of the checklist as well as video and sort of what types of questions we asked. So this is a paper version of the checklist, and it was broken up into 4 domains. My understanding, medications, self-management, and my follow-up, and then the patient had a place to enter their concerns. So, they had questions. We asked them questions about, do they know their main reason for being hospitalized? Questions about their medication. I understand what medications I will be taking, about their self-management. I understand what signs and symptoms I need to watch out for. My follow-up, I have, for example, I have the name and contact information of the hospital provider I can contact if a problem arises after I leave the hospital. And they could answer yes, no, or unsure to any of these questions. What we also realized is that we needed to provide patients a more interactive way of viewing this information and going through this information. So we made these videos, and we basically, one of our residents, Denise Pong, we made a script out of these questions, and then she recorded this video basically on our iPhone, and we sort of put some headers in there, and we made it very professional looking, and then we uploaded it to YouTube, and we were able to show these patients this standardized video. And it was so successful that we decided to make a Spanish version of it as well. So basically, we would go up to patients about 24 hours prior to their expected discharge. They would see this video. They were offered to see this video and then complete this checklist either in the patient portal or through REDCap, and that information would then get to providers in our vendor EHR via this dashboard. So as I said, we used basically REDCap's API to port the information from the REDCap from the survey directly into the dashboard. So upon submission, a checklist would be triggered in the dashboard, and patient-reported data would be available in real time. The providers could then review the checklist in the safety dashboard, and then there was also a link so that if a patient requested post-discharge messaging, they could initiate the post-discharge messaging from this pop-up, and we used a secure messaging vendor called Imprivata for this. So now I want to talk a little bit about our implementation and usage and adoption. So 752 medicine patients were approached from January to June of 2018, and the checklist was submitted for about 510. It was not submitted for 242 for the following reasons. The patient was unavailable, it was not appropriate per the RN, the patient declined in just 41 cases, or the patient did not speak English or Spanish and no caregiver was available to approach, or the patient did not respond to the email when reminded, and only a few number of cases we encountered technical issues. So what are the demographics of non-submitters? So they tended to be older. They more often were Hispanic and non-English speaking, had non-standard insurance or self-insured, and had higher DRG weights among their length of stay, and were discharged to a destination other than home. So there seemed to be some disparities in who submitted a checklist versus those that did not. In terms of usage of each of the PDTK, we broke it down by different components. So about 81% who were offered to watch the video actually decided to watch it. And then of the 510 who completed and submitted the checklist, most of the time it was the patient. There were about 13 caregivers who did it on the patient's behalf. Most often we did this through a web-based REDCap survey. The patient portal was used by about 10%, and this was partly because the enrollment for the patient portal was independent of this study. In terms of what patients are reporting, so there were about 2,100 or 2,164 concerns, and these were things that the patient checked no or not sure. So the majority was medications, related to medications. About 30% of questions, concerns were related to medication, and 30% were related to follow-up. So things like understanding changes to medications and how to get to and take their medications, as well as time and date of appointments and how to get to them. On the dashboard side, the number viewed by the clinical staff, it would say it was viewed by clinical staff in about 41%, and these were the times that it was accessing the dashboard. And typically it was a nurse that was doing it, less often a physician. And finally, for those patients in which the secure messaging was provided, about 33% requested, but interestingly, only 3%, or 3 physicians or 2% actually initiated the post-discharge messaging thread that the patient requested. So here's an example of a secure text exchange after discharge. And basically, you know, this is actually a case that I had when I was testing this out, and I initiated this, and I was curious about what the exchange would be like. And you know, basically, I didn't get any texts, any messages until like maybe a few days later, after the patient said I don't have any questions, and just thanking me to making sure that for everything that was going well after discharge, and really nothing concerning. She said everything was, otherwise everything was okay with the discharge plan. So that was one of the examples. In terms of implementation themes, I also wanted to provide to you an idea of sort of what some of the description and quotes of the different themes that we find during implementation. So for the checklist and the video, it was very valuable for patients, but patient utility depended on the timing of administration. So patients were saying things like, I may think of questions I didn't really have, definitely worth it, it actually makes you think. On the dashboard side, there was often low awareness and variable of the use of the dashboard by different clinicians, and the workflow was variable. So some people did not know that the discharge checklist, typically a physician did not know that it was on the dashboard. And you know, some people said that, well, entering the EDD, expected discharge date, is really not my workflow. And then some people had concerns about what green flags meant on the dashboard. Did that mean that the patient was ready for discharge? So there was low awareness, variable workflow, there was some lack of optimization, and probably some level of inconsistent leadership. So in terms of our evaluation study, we also did a pre-post study where we enrolled patients at the time of discharge. We consented them, and then we for follow-up within 30 days, where we talked to them on the phone and asked about their post-discharge period. So we approached about 358 pre and 320 post. We enrolled about 250 pre and 234 post. In the main analysis, there were about 245 patients pre and 234 post. Unfortunately, we only got about a third, a little less than a third to follow up in the pre, a little more in the post, about 99 in the pre and 116 we were able completed the 30-day follow-up phone call. In terms of impact on major outcomes, so the PAM score, the mean PAM score in the pre was 63 and an increase to 66.4. It was statistically significant in the unadjusted analysis, but when we adjusted for basic demographics, that was no longer significant. And then the other way we looked at this was the proportion of patients who were highly activated, below level of 3 or 4 on their PAM score, and that increased from 56.7 to 59, but that was not statistically significant. In terms of healthcare utilization, we didn't really see much change in readmissions or early readmissions. What was interesting, and we're still analyzing these data, was that in the post at 30 days, when we asked them about the PAM scores, it actually decreased in the post. And one of the things that we suspect is that there may have been bias in our sampling. The patients tended to be a lot sicker, had longer length of stay, and more often went to rehab. And so that may have been a confounder in our analysis. So some of the lessons learned with regard to the implementation barriers, I think it's been last time talking about some of these things as well, some of the strategies we are suggesting to promote use. I think from the perspective of the video, timing and access of the video after admission to unit is important, so making it available from the portal, on the bedside, television, and encouraging nurses to have patients watch the videos. But another barrier was that it was too generic or impersonal, and so one of the thoughts was to create videos for each attending and play the video for the patient's current attending by linking that specific video to the treatment team in the EHR. So when attending, the patient will have a video based on their current attending. There were also some, with regard to the checklist, there's timing and administration issues, the optimal timing of when the checklist was administered for specific categories. There was also barriers related to patients' belief that that clinicians will address all these items before they were discharged, as well as sometimes the checklist responses were out of date due to discharge delays. So getting the workflow to update the checklist after initial submission is really important. So in terms of the safety dashboard discharge column, there's variable data entry of some of the key data elements like expected discharge date and non-medical barriers. There are also several competing quality improvement interventions, and finally, poor specificity of the patient-reported concerns viewed in the dashboard. So, one of the suggestions was providing a link to the discharge checklist questions from within the dashboard with their responses, and potentially linking this to specific clinical actions, sort of like if there was poor understanding of the main diagnosis, then the clinicians would be encouraged to update the after-visit summary with condition-specific educational information. With regard to the secure post-discharge medicine, the key barriers were physician resistance, as well as managing patients' expectations about whether physicians will initiate secure messaging. And I think the key thing here is to make sure that we frame the initiation of secure messaging thread as an opt-in process. But I think for something, a feature like this to be adopted and more widespread, I think the payment system will need to be reformed and such that use of this type of tools will be aligned with value-based incentives for hospitalists. So in conclusion, there was a high degree of acceptance by patients and caregivers for completing the checklist and watching these videos, and I think it's a potentially useful strategy for engaging patients in discharge preparation when done at scale. Many patients reported some uncertainty about specific checklist items. That may indicate that they may not be well prepared for discharge. There was modest use of the EHR integrated components, and I think more work is required to make the information more actionable for clinicians. And then many patients requested post-discharge medicine messaging. However, a few clinicians actually acted upon this request. And I think this demonstrates that patients really want to be able to communicate with their physicians during that transition period after discharge. But often clinicians may be unaware of this, but really there's a lot of resistance and they have no incentive to do this. And so I think there's those types of barriers in place that need to be addressed before this could be adopted. And finally, key outcomes such as patient activation or resource utilization, I think these are unlikely to be improved unless a lot of these adoption challenges are addressed and the interventions used more routinely a part of clinical operations, which is something that we're working on here at Brigham. And I'd like to thank my team over the last 2 years, included research assistants, program developers, residents, statisticians, and some of my mentors. Thank you.
Thank you, Dr. Dalal. As a reminder, we will be taking questions after both presentations, so please submit any questions you have for Dr. Dalal using the Q&A panel. Let's move on to our second webinar presentation, which is being led by Dr. David Liss. Dr. Liss is a health services researcher at the Division of General Internal Medicine and Geriatrics at Northwestern University. He is interested in designing, implementing, and evaluating new approaches to improving the quality and value of primary care delivery. His particular expertise is in the patient-centered medical home and care coordination. And now, I would like to turn the control over to Dr. Liss.
Thank you. Thank you, Commander Wyatt. And thank you, Anuj, for a really interesting presentation. Good afternoon, everyone. It's a pleasure to be here today. As I begin, I'd like to acknowledge, of course, research is, of course, a team sport. I want to thank all of my colleagues on our research team, as well as our project stakeholders, as well as the funders of this work who allowed this study to happen. Care coordination is a core element of primary care, as defined by Barbara Starkfield. Despite its importance, care coordination is quite difficult to successfully achieve in practice, particularly when you talk about care coordination between organizations. Organizations, for example, may have different electronic health records. They may have different staffing models. They may have different quality targets. All of these things make coordination difficult between organizations. Nevertheless, care coordination is quite important. There's a clear need for it by primary care teams during care transitions into and out of the hospital. For example, when a patient arrives at the emergency department or ED, a primary care team could conduct outreach to the patient and the ED to learn what's going on with the patient, maybe even inform what kind of care is delivered in the ED. Once a patient is admitted, there's the potential for the primary care team to begin discharge planning, getting ready for when the patient does come home. And once they're discharged, there is obviously the need for timely follow-up, addressing the patient's needs, helping them transition back to the community, and hopefully preventing them from needing to return to the hospital. When it comes to care coordination and health IT, there are many types of resources or technologies available to providers. Health information exchange can be a really powerful tool for notifying providers about patients' use of hospitals and visits to hospitals in geographic regions. However, recent research has shown that about less than half of physicians or less than half of regions around the country are really using fully operational health information exchange. Additionally, health IT use itself, particularly use of electronic health records, is not associated with physicians receiving discharge information for their patients. There's also technologies that are available to patients, patient portals or patients' access to electronic health records. Although that's available to many patients, there has been low use by vulnerable or traditionally underserved populations. In contrast, smartphone ownership is really nearly universal amongst Americans age 65 or less, amongst non-elderly Americans. And when we use our smartphones, whether we sort of realize it or not, we're often using location tracking technologies. Maybe we're using navigation to get from point A to point B. Maybe we're receiving ads based on our location. Sometimes we're hailing our rides using services like Uber or Lyft that are highly dependent on location tracking. So our team was interested in using location tracking and smartphone location tracking for care coordination. To explore this topic, we first conducted some focus groups with patients who were smartphone owners at the study site that I'll discuss a little bit more in a couple of slides. Most of these patients actually had Android phones. They weren't iPhone owners. They expressed limited concerns with location tracking for care coordination, perhaps less than we would have initially assumed with regards to privacy or other kinds of concerns. They did say, not surprisingly, they didn't want to be inconvenienced by internet. They didn't want to receive lots of false alarms. They didn't want the battery to be drained on their phone, really kind of standard really requests or needs out of a smartphone app. When we interviewed clinicians and care managers, not that surprisingly, we heard from clinicians that they often do not know when their patients are in the hospital. From one of the members of the care management team at this organization, they said to us, we just want to know that they're there, that patients are in the hospital, and then this care management team could triage or coordinate care for these patients. So armed with that information, we set about conducting the current project funded by AHRQ. Our overall project aim was to design and implement an intervention that uses smartphone location tracking to facilitate care coordination following a hospital encounter. And there were really three kind of elements of this intervention. The first was that the app uses smartphone location tracking to identify a hospital encounter. And here, when I say hospital encounter, what I mean is an emergency department or ED visit or inpatient admission. Once the app actually identifies a hospital encounter, then they provide a timely notification to the primary care team about this event so that the primary care team can then conduct coordination according to existing organizational protocols. This study was conducted at a federally qualified health center in Chicago. It's called Erie Family Health Centers, sometimes known as Erie. Erie has a care management program for high-risk patients in a local Medicaid plan. Care managers, amongst other tasks, are charged with conducting care coordination when patients visit the hospital. This project had two sort of separate or two distinct phases. And our first phase related to our initial app build as we were first creating the app. We first began with a design retreat attended by members of the research team as well as patients at this study site. And we began designing an Android app beginning with only an English version. In terms of our location tracking, the approach we used was something called geofences. And a geofence is really just specific latitude or longitude coordinates, which we use to define 41 hospitals shown on the right here in and around the city of Chicago. And when we designed the initial app, we internally conducted what we call some alpha testing and tested for bugs, just making sure that it was sort of working as intended. In terms of the workflows we designed, first what happens is that for a patient who had installed the app on their phone, if their phone was within a hospital geofence for 45 minutes or more, this kind of notification popped up on their phone asking, are you a patient in the hospital now? If that patient said yes, they were then brought to a confirmation screen saying, okay, got it, we're sending a message to Erie to let them know that you're in the hospital. And then a secure eFax was routed to the primary care team. And this FQHC at this study site, they elected to receive eFaxes. There were other kinds of secure electronic communications we could have delivered, but they had software that allowed them to index this message into the patient's EHR. I should note that patients, when they downloaded and installed the app at the time of installation, they entered their name and date of birth into the app, and what that did was that allowed them in these notifications when they were sent to the primary care team to contain the patient's name, date of birth, as well as some other information about our best guess as to which hospital they were at and when they arrived. And that name and date of birth data allowed this organization to directly sort of integrate these messages into the EHR, into the patient's chart. In so doing, the care manager was notified about these events and then could conduct outreach and follow-up according to existing protocols. I'd also like to note that there were similar workflows that we employed at the time of discharge after a patient or a user had confirmed they were in the hospital. Once the phone left the hospital, left that geofence, a couple hours later, similar alerts fired with similar workflows. Again, a message being integrated into the EHR to notify the care manager about discharge. So our evaluation for the first phase of the study is what we called our beta test. Our aims in our beta tests were to evaluate the app's ability to identify when a user visited a hospital. And here what we mean, we're really just more interested in the sort of testing the location tracking. So whether or not a patient was receiving emergency care, we weren't as worried in. It's just sort of testing the location tracking capabilities, even if they were just, say, for example, visiting someone in the hospital. And we also wanted to identify barriers to implementation so that we could address them in a subsequent app build. We recruited participants from this care management program, which can high-risk patients with Medicaid insurance. Patients downloaded and installed the app on their phone for 3 months. Any patient-reported hospital encounters were confirmed by chart review. So in this small initial beta test, we had 12 patients who provided valid follow-up data, relatively young, average age of 38, largely female, largely racial ethnic minority, high-risk sample with high rates of chronic illness. We observed in the beta test that these 12 participants obtained health care over a 3-month follow-up at 7 different hospitals across the region. While they obtained care, there were 5 confirmed emergency or inpatient encounters at 4 different hospitals. There was also lots of outpatient utilization, whether for specialty care or otherwise. And there were also 7 other what we described as events when they visited hospitals, such as times where they were visiting loved ones who happened to be admitted. In calculations of the sensitivity of the app to be able just to detect, again, not whether it was an ED event, whether it was an ED or inpatient visit, just to detect the location of the phone in the hospital, depending on whether or not we included outpatient visits in our calculations. It had at least a 57% sensitivity to detect these events, so moderate sensitivity, and a positive predictive value. When these notifications fired asking a user if they were in the hospital, at least 90% of the time that was positive predictive value of them actually being inside a hospital building. There were, of course, several observed barriers to implementation in this initial test. A couple of them there were, not surprisingly, we found limited cellular service inside hospitals. These are big, large buildings where there can be problems with cellular service. Another barrier that we observed was that some of our users reported confusion when they were asked if they were, quote, in the hospital. If someone was in the emergency department, there was some confusion as to how to answer that question if they hadn't yet been admitted. So we used this feedback in making modifications to the app and the intervention in our sort of second phase of the study. So some changes were made with it. We made some changes in our sort of detection algorithm to increase its sensitivity to detect events. We also changed the wording of that initial alert, asking someone if they were now, quote, in the ER/hospital to make sure we were being more explicit about the ED and detecting that kind of utilization. Our second phase of this project was what we called our feasibility study. Using the revised app, our aims were to evaluate time to post-discharge follow-up. So now not looking at the location tracking functions of the app, but looking at actual care processes conducted by the care teams at the FQHC. We also wanted to explore users' experiences and identify potential desired features in, say, a next generation of the app. We now, in this phase of the study, had an English and Spanish version of the app and included English and Spanish speakers who downloaded and installed the app for 4 months of follow-up. All patient-reported hospital encounters were confirmed with paid Medicaid claims data. And we defined timely follow-up according to existing protocols at the study site, where they defined follow-up as contact with patient within 3 business days of discharge or an in-person visit within 1 week of discharge, again, according to existing organizational protocols. In this feasibility study, we had 57 patients who enrolled and provided valid follow-up data. Again, relatively young study sample, mean age of 42. Largely female. In this phase, we had a higher, again, largely racial ethnic minority, but higher proportion of Hispanic participants, reflecting now that we had a Spanish language app. Nearly 1/3 of participants had limited health literacy. During this phase of the study, we had what I refer to as a bit of a curveball. Although initially things had been going pretty smoothly, all of a sudden there started to be some sporadic transmission of data. We were seeing that the app was apparently going to sleep on patients' phones. And we ultimately came to learn that one of the major Android phone manufacturers had changed their background app settings, some of their battery saver settings. I think many of us see commercials with phones bragging about their battery life. Well, we unfortunately were caught in the middle of one of these changes, where unfortunately it affected the performance of the app sort of midway through the study. Nevertheless, we obviously continue with our evaluation. What we saw just in terms of utilization, we saw that amongst these 57 participants, they had 23 confirmed emergency or inpatient visits, and that occurred at 12 different hospitals across Chicago. And what we have here listed is the different kind of information sources used to identify some of these hospital encounters, as we call them. Unfortunately, obviously, the app did not perform as well as we wanted it to. But I think perhaps most interestingly here, what we see is this kind of wide variety. We see a few different information sources. The hospitals themselves, also 7 of these encounters were reported to the care teams at the FQHC by hospitals. Patients self-reported some events. There's also, it's a payer-specific, it's a payer-linked portal that the study site had access to. It is kind of like it's like an electronic kind of infrastructure or portal that connects with some of the systems actually at local hospitals, which is really kind of cool. The potential issue with being is that it's payer-specific, so it's for this one payer, and it's only with some Chicago area hospitals that they have access to this portal. But again, we had 23 confirmed encounters at 12 different hospitals. Looking at our primary outcome, which was timely follow-up, for 16 of 23 of these encounters, about 70% of the time, care teams at the study site were able to complete timely follow-up. And my apologies for the small text here, but looking here at, again, these sort of 4 ways that care teams were notified about patients' visits to hospitals, we see really a wide variety. We see a really kind of a fragmentation of kind of information flows, kind of an unpredictability for the care teams, different, really not really any kind of predictable patterns into how they're being notified about when their patients go to the hospital. Obviously, I think probably a pretty difficult environment to be operating in, but we do see nevertheless nearly 70% of the time with all of these fragmented kind of information flows, they were able to complete follow-up with patients. For 7 out of 23 events, roughly 30% of the time, they did not complete timely follow-up. If we look, you can see in 3 rows are kind of empty there. That means there were 3 of these events where they received no notification about patients going to the hospital, which obviously makes it essentially impossible to be following up. But there were also some events where they did receive notification, but again, in the context of these kind of fragmented, disorganized kind of information flows, ultimately they weren't able to sort of achieve that primary outcome for patients. When we spoke to patients or users about their perceptions of the app, in general, in the qualitative data, some of the things we heard, patients thought it was a good idea. They liked the goal of the app. We heard things like the goal of the app was comforting. In terms of it being an efficient or effective solution, patients said things like it can close the gap when the ball is dropped. Patients understood how there could be gaps in information transfer here. Obviously, though, the technical difficulties we experienced were a barrier to acceptability among some patients. Patients also told us about some desired new features that they would like in sort of a next generation of the app. Some of them wanted to be able to manually report when they went to the hospital. They didn't want to wait for automated notifications from an app. Some of them wanted a list of times they went to the hospital. So yes, it was great that this app could be notifying their care team in real time, but 2 weeks, 6 weeks, months later, they wanted to be able to consult a list of their own telling them which hospitals they went to and when that occurred. And there was also some desire for some ability to enter some free text to provide some information to their care teams about these events. So in summary, we developed the care coordination app and implemented it in a high-risk, low-income sample here in Chicago. Unfortunately, in the second phase of the study, there was low detection of events by the app due to technical issues, but these are issues that we found to be fixable, and in our sort of next generation of the app, we're able to address them. In general, we found that patients understand and support goals of the app. That said, there was limited use, even in a high-risk sample. Only about 1/4 of patients actually went to the hospital during 4 months of follow-up, and there were limited opportunities to be using the app. There are, of course, limitations such as our small sample size, observational nature of the data, as well as the fact that these results may not be generalizable to settings where primary care teams are comprehensively being notified about when patients do go to the hospital. Going forward, I think tools like this have the potential to do a few different things. One is to improve patients' experience. Again, patients we spoke to understand how the, quote, ball can get dropped, and if you can be bridging these gaps in ways that are relatively efficient for the patients, there's an opportunity to improve patient experience. There's also opportunities for reimbursement. For example, CMS, Medicare, has a CPT code. They offer payment for transitional care management after inpatient discharge. One of the core responsibilities for that is conducting timely follow-up with patients soon after discharge. Obviously, to do so, you need to be notified about when patients arrive at and are discharged from the hospital. And perhaps most importantly, there's maybe the potential to reduce avoidable inpatient use with tools like this. If we think about preventing readmissions, when care teams, if they're notified when a patient is admitted as an inpatient, again, they can begin doing discharge planning, getting ready for when the patient is discharged, maybe even prepping a follow-up appointment, and then obviously conducting timely follow-up, meeting the patient's needs immediately post-discharge to make sure that they don't have to return to the hospital. And also, I think interestingly, there might even be the potential to prevent some initial admissions to the inpatient setting from the emergency department. Now, that depends on really timely notification once a patient arrives at the ED, and for infrastructure to be there by primary care teams to conduct outreach and perhaps assuage the concerns of both patients and emergency care teams, that the primary care team will be sort of ready and willing and able to address patients' needs if they are not admitted as an inpatient and instead are discharged to home or to the community setting. So in conclusion, smartphones can be a valuable care coordination tool, especially for vulnerable populations. We found that there's limited need for user training on these apps once they've been sort of installed or a patient's been onboarded onto the app. I also think that given their limited use, there's potential for kind of expansion of this kind of an app, or integrating it with other kinds of app functions. Perhaps it's tracking trips to other locations, specialty care around the community, maybe even social services around a region. That said, I would sort of caution, having learned the hard way, certainly developers and researchers should be mindful of operating system updates or changes in manufacturer settings. There are some challenges, but there are also opportunities. For example, I've heard that the next generation of iPhones are going to have more precise kinds of location tracking. And certainly there's a need to partner with stakeholders at every step. You certainly cannot design a patient-centered app if you're not working with patients at every stage of development. And to integrate a tool into care team workflows in a way that's not disruptive, you obviously need to be working hard with these sort of care teams on implementation issues. So I'd like to thank everyone for listening today. I really appreciate the opportunity to be here, and very much appreciate the opportunity. Happy to pass the ball back to Commander Wyatt.
Thank you, Dr. Liss. Please feel free to submit any questions you have for Dr. Liss using the Q&A panel at this time. Moving on to our final presentation of this webinar, which is being led by Dr. Sharon Hewner. Dr. Hewner is an associate professor and chair of the Family, Community, and Health Systems Science Department at the University of New York at Buffalo. Her work couples social science, family medicine, nursing, and gerontology with experts in biomedical informatics, engineering, and computer science. Dr. Hewner's health systems research identifies opportunities to link health data across settings and improve the use of health information exchange to inform redesign of electronic health records. As nursing moves to community-based, technology-driven care, Dr. Hewner's background in data analytics, interprofessional collaboration, and technology aligns to transform care delivery to persons with complex chronic disease. And now, I would like to turn the control over to Dr. Hewner.
Thank you, Commander Wyatt, and thank you to my two previous presenters for their work that really laid the groundwork for here. Dr. Dalal looking at the inpatient side, and then Dr. Liss really focusing on what happens on the outpatient side. And what I hope to do today is actually show how we can maybe integrate those two. Let's see. So I'd like to acknowledge, first off, my research collaborators, and I think that what's unusual about my group is that it's first off led by nursing, and we've brought in a number of people from different disciplines, family medicine. We worked very closely with industrial and systems engineering, and that has been a really interesting approach. And we worked with the University of Minnesota Family Medicine and Community Health in using a tool that they developed to assess social determinants. Our clinical partners was the study site, which is a federally qualified health center in our region, and we worked with our Healthy Link, which is the clinical information exchange in Western New York, and we did the outcomes analysis using de-identified data from the New York State Medicaid Data Warehouse. And the project was supported by AHRQ, for which we are very thankful. So we sort of got into this problem because from the perspective of the primary care practice, they had no idea when patients were admitted to the hospital, and they couldn't possibly do care coordination when they found out 3 weeks later if a patient came for a follow-up visit to manage anything. So what we wanted to do is figure out a way to get the information to them, but we didn't want to overwhelm them with information. So one of the things that we really had to figure out is what was the population that we wanted to target with the care alerts, and how did we make sure that we weren't sending them a lot of information that was not actionable. We also had to figure out how to deal with HIPAA requirements about data sharing, which was a challenge, and think about how could we actually integrate the assessment of social determinants of health into the screening phone calls that the nurses made on outreach. So our ultimate goal was to reduce low-value utilization, either inpatient or emergency department, in the population with pre-existing chronic conditions, and to increase outpatient follow-up, especially after discharge. And these goals aligned very closely, certainly with a national emphasis on avoiding admissions, and with the New York State Delivery System Reform Incentive Program, or the DSRIP, which was a 5-year statewide project that was started in 2015, which coincided with the initial year of our intervention. So the setting was an urban patient-centered medical home with a roster of about 6,000 individuals, a third of them on Medicaid, and many with developmental disabilities. The population that we chose to target was those who had a pre-existing major chronic condition because we felt that those people at the time of discharge would be really likely to run into problems with medications or confusion about what they're supposed to be taking or needing additional assistance in the home. So we felt they were a good target population. Our intervention was a technology-supported registered nurse outreach, which was delivered from the primary care practice, and we evaluated our outcomes looking at the change in inpatient and emergency department utilization rates in both study and comparison practice sites. And our evaluation was largely descriptive statistics, but we were also able to do a negative binomial regression to determine whether or not the results were statistically significant. So we actually had a number of different technology and big data approaches, one of which was targeting the right population. A second one was alerting the primary care practices, and we used our health information exchange here. We really wanted to start to integrate social determinants of health assessment during these outreach calls, and then doing the outcome analysis, and I'll talk about each of those in turn. So our analysis relied on using existing de-identified electronic data from the Medicaid Data Warehouse and the interoperable exchange of health information across healthcare settings. We developed automated care transitions alerts that were delivered using health information exchange within 24 hours of discharge. It was based on the admission, discharge, and transfer notification that was automatically coming to our health information exchange. And what they had, just about at the time that we started the study, they started doing data dumps of ADT data to the primary care practice. And not surprisingly, what happened was that it completely overwhelmed their systems. And so one of the early challenges that we faced was how to identify which of the ADTs were really important for the primary care practice to know. We developed a complexity algorithm for case identifications, and the same one was used for outcomes analysis. We looked at social and behavioral determinants of health and integrated that into the care planning process within the primary care, and that also then would be shared through health information exchange back into the their system. And then we did health outcomes analysis that really was trying to focus on demonstrating the value of the nursing intervention. So this complicated picture gives you at least a little idea of what we started with. So the first thing that we wanted to do was identify the patients who actually had chronic disease, because we really didn't want the nurses to be making calls to every patient who was discharged from the hospital. What we did is we looked at the billing claims from the primary care practice. They gave them to us with just the a patient record number and the diagnosis that that person had had over the last 3 years. And we just classified people by whether or not they had one of the major chronic conditions. And we submitted that list to our health information exchange, where they used that to only provide care alerts on patients who were discharged from the hospital who were on the list, those who had chronic diseases. Then what happened is that when someone was discharged from the hospital who was on that list, and the list was stored in the clinical data repository at our health information exchange, they would send a care alert to the primary care practice that included the reason for admission, the hospital that they were in, and the list of the chronic conditions that we knew put them at risk for needing care coordination. When the nurse care coordinator in the primary care practice got that message, she would make a outreach phone call to the person within 24 hours. Hopefully over the weekends it was a little bit longer, and just find out how they were doing, look at their medications, and they would go through at that time to complete a 12-item social determinants of health assessment tool, and then they would record those results in the transition of care note, which was incorporated into the electronic health record and ultimately shared back with our health information exchange through the continuity of care document. So we tried to make a closed loop here, where the people were identified, we sent a message, the nurse did something, the information got into the primary care electronic health record, and then was submitted back to the health information exchange, where it would be available for anyone who was providing care for that individual person. So the way that we targeted the chronic cohort is using an algorithm that I developed called the Complexidex. And this Complexidex was really designed to try and identify the 32% of the population that had major chronic diseases. The practice was also interested in people who were frequent emergency room utilizers, and they did a different kind of intervention with them. And the rest of the population really did not get any particular intervention at all from our intervention here. Let's see. Now, the PCAM, which is the Patient-Centered Assessment Method, has been developed and refined at the University of Minnesota. And it is a 12-item questionnaire that has 4 domains: health and well-being, the social environment, health literacy and communication, and service coordination. And they're all set up as questions where the person can choose one of 4 categories that are increasingly severe. So the lowest level is always no problem, and the highest level is a severe problem. And there was no particular way to score this mechanism, but it did allow the person who was completing it to sort of identify what were the big problem areas. Originally, what we did is we simply put in a value 1, 2, 3, 4 for each of the 12 questions that were in here, and that actually did not communicate very much information. So we really had to think about how can we make this exercise something that is going to be a value add for the nurses. So what we did is we developed a clinical decision support tool that transformed the paper-based tool into information. So this tool, we used some of our computer science students at the university to develop this. And what you can do now is you can slide your little slider along to decide where you think that person is. And when you do that, depending on what level they are, it will either identify it as a strength or a weakness. And if it is a weakness, it will be incorporated into a care plan that can go directly into the electronic health record. So the nurse can copy and paste that directly into the electronic health record. So those 4 interventions combined really tried to address the quadruple aim. So the first thing is that we really wanted to have the nursing documentation and the development of a care plan become something that was very central for these complex patients that we were trying to reach. Because there were the secure alerts, the nurse care coordinator actually had time to try and get a discharge summary from the hospital before she made the phone call. But she also, at the time of the phone call, was able to identify some things that might actually need immediate intervention to prevent or potential readmission. The nurse's role was a huge expansion. Originally what happened in the primary care practice was there was a half-time diabetes nurse educator in the practice, and what we paid for with the grant was for that person to become a full-time person, so 50% of her time was in working with these high-risk patients. She received the calls, she made outreach calls, she identified problems, she engaged team members, they updated the interprofessional care plan, and we did a lot of workshops and weekly feedback to the nurse during implementation to support and reinforce the benefit of that expanded role. We spent a lot of time trying to standardize and synchronize workflows. That was certainly a role that our industrial and systems engineer colleagues worked very hard on. And I felt that it was very important that the nurse was co-located with the primary care team because she actually had the opportunity then to see patients when they came in to the practice. Although she didn't do the physical exams or anything, she was certainly involved and she was there as a resource and she was there to identify problems that might be coming up. So I liked the way that that changed the role of the nurse in the primary care practice. So I'm going to talk a little bit about the results of the program, but I should let you know that we did not limit the intervention to the Medicaid population. So anyone with a chronic disease who was discharged from the hospital, privately insured, Medicaid, Medicare, they all got the same intervention. However, we had access to the New York State Medicaid data warehouse, and all of the results are based entirely on the Medicaid population. And we felt that was appropriate because we thought if there was an intervention that actually worked for the Medicaid populations, chances were pretty good that it would work for our other populations who are going to have different, or at least maybe fewer, but definitely different kinds of social determinants that would be part of their issues. So, when we did this, there were 419 persons in the chronic care cohort at the primary care practice. So that's our denominator of patients who were eligible to be part of this study. We also had 2 urban comparison practice sites that had large Medicaid populations. And then we also did a comparison with the remaining Medicaid population in the 8-county region of Western New York, just to see what was secular trends going on, because, as I said before, this was happening concurrently with the New York State Delivery System Incentive Reform Program, and which had very similar goals to our project. So, when we look at the utilization, we have inpatient emergency department and outpatient events that we were counting. And we looked at the rate of each of those in 2014, and we then looked at the rate in 2015. And I've only listed here just the intervention site and the other regional Medicaid, just to show you that at baseline, our inpatient rates were fairly similar in the intervention site and the rest of the Medicaid region, as were the emergency and outpatient visits. So we weren't a lot different. However, we do know that the rate change was greatest in the intervention site, and that at the intervention site, they met the Delivery System Incentive Reform Program's 5-year goals in the first year of the program. So in 2015, our intervention year, they met the goals of the DSRIP program, which we were very excited about. So I like this graph the best because it makes it visual to take a look at what happened. So we have the intervention site, comparison A, comparison B, and then the fourth dark color is the other Medicaid, so anyone who wasn't in one of those 3 practices. And we found that there was a 25% reduction in inpatient visits in our study site. And the other 2 comparison practices, one had an 8% reduction and the other had a 3% increase. And you can see here again that in the general Medicaid that it went down. Maybe even more dramatically, we had an extremely large reduction in the emergency room visits with this intervention, even though we did not target as part of the intervention emergency department, the practice did, and once they sort of figured out what we were doing with inpatients, they adopted on their own to do a different kind of outreach with people who went to the emergency room. So they had the largest decrease in the rate of emergency room utilization. But I think what's really important is that they also had the largest increase in the outpatient growth rate. And so what was happening is that they were shifting care, not just limiting care or limiting access to care. And you can see even in the overall Medicaid that there was only a 4% increase in outpatient visits, even though there was a fairly dramatic reduction in inpatient and emergency room use. And so I really wanted to see that shift happen. So this is the results of our negative binomial regression, and you can see in the very large Medicaid population, the other group, everything is significant, which is not so surprising given the size of that population. But in our study practice, we had the closest to significance in inpatient rate and significant emergency rate reductions and increases in the outpatient rate. So one of the things that I think is important is to think about how can we show the value of our interventions. And what we did here is try to determine what were the avoided inpatient and emergency room events, and then put some kind of cost value on that. So what we did is if for every avoided emergency room, we took the average inpatient cost back in 2015, which was $10,855 for us, and for emergency room, it was $1,077. So all we did is look at how many events were avoided based on the rates in 2014 and 2015, and then calculated out what was the potential savings. So in our study group, there was a potential savings of almost $700,000, which is really good. And that was an average of $1,669 per person in the practice with a chronic disease. So we're only looking at the population with a pre-existing chronic disease. And remember, this is also only on Medicaid patients. The reduction was quite a bit less in the comparison site A and comparison site B. And for the overall region, there was a significant increase, or excuse me, a significant reduction in cost, but not quite as much as in the study site. So that was really helpful for me to use to really sell the success of this project, that this is a way that we can save money for the healthcare system. And as it turned out in our primary care practice, because they did so many more visits, because of people coming in with the increase of rate of outpatient visits, what they felt was that it more than offset the cost of the nurse. It was really important to be able to show that. So the short-term outcomes in the practice. First off, the practice felt that they were using the same resources more efficiently and effectively without increasing the workload burden on providers, which is really important. So that care coordination really made the doctors and the nurse practitioners' jobs easier within that site. It did reduce unnecessary hospitalizations and emergency room visits, and it was really by providing a very supportive person-centered care during the transitions. So I think that technology can be really useful in improving care coordination, but we have to be very smart about how we use it and really think about what's going to work for people. And here, they really have to link the two settings. So I think that using the data that's generated at the hospital and sending it to all of the primary care practices worked incredibly well for us once we figured out how to clean up the ADT data and to limit it to only people with chronic diseases. We had an opportunity to really understand about the social determinants of health, and what that led the practice to do was, in addition to having a nurse who was doing care coordination, they then hired a social worker, and those two worked in tandem. So I think that in order to move from the triple to the quadruple aim, we have to pay very close attention to workflow, thinking about alerts that are going to be meaningful and really target the appropriate populations. And there's lots of implications for management, practice, and education. And I just wanted to give you an update of where we are 4 years after completing the intervention. So as of 2019, the sharing of ADT information is now going out to all primary care practices, and in fact, our Health Information Exchange is able to send the number of visits that people have had in any hospital, so the primary care is getting some really good data there. And the growth of the care coordination is really moving forward very quickly. The other thing is that our study practice has become the model for how to do care in the region, and has been doing a number of presentations. Everybody's calling them up to find out what are they doing and how are they doing things. I think that there's a tendency to undervalue the importance of having a nurse in that role as the care coordinator. But overall, it's made a huge impact, not just in this one practice, but really across the entire 8-county region of Western New York. So with that, I will pass the presentation back to Commander Wyatt. Thank you.
Thank you, Dr. Hewner, and thank you all again to all our presenters for their very informative presentations. As a reminder, please submit any questions you have of either of our presenters using the Q&A panel. This concludes the content portion of our webinar. Now we have a few minutes left for questions. You can type into the Q&A section of the WebEx portal. We may not be able to get to them all, but we will answer them all in writing and send answers out to all the attendees. My first two questions are going to be for Dr. Dalal. So the first question, Dr. Dalal, is what type of challenges a healthcare organization may encounter trying to implement the discharge checklist you described?
Okay, hi, thank you, Commander Wyatt. Yeah, so I think the biggest thing that we learned is sort of when's the right time to administer the checklist to patients, who's going to administer it, and how do you get the results to the clinicians. And so, you know, right now, a lot of, because as part of the study, we had an RA facilitated workflow. I think ideally patients would just be able to fill this out on a patient portal or on their mobile device, and then this information would just be ported into some workflow within the electronic health record. And so that integration, I think, is important. And that's kind of the model that we've sort of developed. But you know, not every patient would be able is going to be able to fill it out on a mobile device, or you know, hopefully their caregiver will be able to do it on their behalf. But I think understanding, like, you know, like trying to align this with sort of as patient portals reach the inpatient setting, I think that would be, and figuring out how to align it with that, I think is probably the best strategy forward. But I do think the challenge is sort of, you know, making sure that it is well integrated into both the patient as well as the clinician workflow. So I would say that's one of the main challenges.
Okay, thank you. The second question I have for you, Dr. Dalal, we had a lot of questions on the panel that talked about physicians and their involvement. So what do you plan to do to incentivize physicians to do the post-discharge follow-ups?
Yeah, the post-discharge messaging, that was an exploratory feature. And, you know, a lot of it was based off just, you know, personal experience as well as experience of other clinicians over time, and some of the you know, baseline work of previous work we have done where, you know, physicians are, you know, if a patient wants to follow up and get in touch with a physician, they generally are able to figure out how to do it either by calling the hospital operator or calling some kind of post-discharge number, and eventually the information gets to them. The problem, and you think of it from a patient's perspective, it's incredibly frustrating to basically call an operator, wait until that the operator then pages the doctor, and then have the doctor call them back. And my thought is that, you know, for, being a hospital, we should be consumer friendly, right? So we should make things easier for patients, right? And so, you know, breaking that down that barrier seems to me a value add. The real concern of are physicians or people going to be inundated with messages? You know, I've conducted some other studies where we looked at messaging in the inpatient setting, and it's the same fear where patients are going to be inundating their clinicians with messages, and the majority of the time that's just not the case. And in fact, the messages have not been that many. I think it's the same thing here. I think a lot of it is just cultural. I think there's a lot of there may be unjustified fear that physicians are going to be inundated with messages, and I think if you talk to them on a case-to-case basis, I think, you know, they probably will find value in some of the cases that, you know, where a patient was being discharged home, had follow-up at a pharmacy, had a wrong medication prescribed, or needed a generic version because of the insurance approval, that this sort of thing would just help break down that barrier. But I do think it's going to take time. I do think payment system has to sort of incentivize that, and as we transition towards a value-based system, I think that these sorts of things need to be sort of incentivized to actually change the culture and the mindset.
Okay, thank you, Dr. Dalal. The next question is for Dr. Liss. I had a lot of positive feedback about the app, Dr. Liss. One of the questions that was asked, once a practice has been notified by the app that one of their patients is receiving care at a specific hospital, what infrastructure care coordination would a practice need to effectively respond to one of these notifications?
Pardon me, thank you. That is a good question. I would say that there's a variety of ways that a practice could respond. I think that there's a lot of flexibility for practices. I don't think that there needs to be a hard and fast rule. Certainly the kinds of you know, infrastructure or staffing that a practice could have in place is going to vary according to the size of the practice, according to its staffing model, et cetera. So, you know, I talked about a federally qualified health center with a really well-staffed care management program. Frankly, it could be as simple as, you know, a physician themselves, or even like a scheduling coordinator calling up a patient to schedule a follow-up visit immediately after discharge, or very soon after discharge, or even pre-discharge. I would say that there is a ton of flexibility there. I think what works for the practice would be fine, so long as they are really focusing on something such as timely follow-up, and focusing on getting realistic workflows in place and communicating that to their patients. As long as their patients know, okay, we're going to schedule a follow-up appointment with you and we'll be in touch soon after discharge, I have a feeling patients would be okay with that. I have a feeling patients aren't necessarily going to be demanding kind of, you know, concierge level care from their care team. I think knowing that their provider knows and having their provider or their care team get in touch when done in a consistent way, that in a way that works for the practice is great, however that does work for the practice.
Okay, thank you. Dr. Liss, you mentioned that traditionally underserved populations generally have had low use in EHR portals. Could you comment a little more on why that is and what is the reason to expect that these populations will be more amenable to using an app like the one that you designed?
Sure. So there's been some research coming out from teams at UCSF, University of California, San Francisco, and maybe elsewhere. When it comes to these EHR portals, first of all, a lot of them were initially rolled out on desktop computers or PCs. When you talk about internet access, when you talk about issues of tech literacy, things like that, a lot of maybe low-income or traditionally underserved populations didn't even necessarily have a PC at home or might not have internet access. So that in and of itself is going to be a reason for low use of these EHR portals. In addition, some work's been done to look at, to just sort of monitor patients as they sort of navigate use of the portals. And they found that there was, patients had difficulty, toggling between different kind of tabs or other elements of the portal. Again, these were kinds of activities that required a relatively high degree of tech literacy that didn't necessarily work well. So which wasn't really, I guess that wasn't terribly surprising. And again, thinking about moving towards apps, when we talk about apps, we talk about smartphone ownership being nearly universal amongst non-elderly Americans. We talk about these things for better and for worse that many of us are glued to for too many hours of the day. These are tools that patients are used to using in their everyday life. And if you can, work with patients to design an app that isn't too complicated, again, on a sort of a platform that they're already familiar with, I have reason for optimism of it being acceptable, perhaps more than a traditional EHR portal.
Okay, thank you. Dr. Hewner, the next two questions are for you. Personal health information and the security of that is in the news now. So how were you able to ensure compliance with HIPAA regulations and protect personal health information in coordinating transitions with your project?
So for us, I was completely blinded to the information that was flowing through the health information exchange system. So as an outside researcher, even though I'm a provider, I was not able to access any of that information. So we just used the routine clinical pathways for them. The analysis was not done on the data that came from the practice, except for identifying who had a chronic disease. So that was something that occurred at the beginning, and I made a list of people, and that got into the clinical data repository for HealthyLink. But I didn't actually have any data. The data that I used in order to analyze outcomes was based off of the Medicaid data warehouse, and that was fully de-identified administrative data, which was really just the fact that somebody had an admission, had an emergency room visit, had an outpatient visit, and during the course of a year, and what their chronic disease status was. So that worked out pretty well. It was hard to develop care alerts when I couldn't actually see an ADT message. So we had to spend a lot of time talking to the nurse care coordinator to try and figure out what was there, what they didn't need to see, what was valuable information. And so we went through a number of iterations for that. But I think that completely separating the analysis from the clinical data exchange worked out really well for us.
Okay, thank you. I know our time is winding down here, but I want to ask you one more question, Dr. Hewner. How are the problems identified using the ePCAM clinical decision support tool incorporated into the EHR or the electronic record itself?
Okay, so what happens is that actually the responses to each of the question has been assigned a LOINC code by the Regan Strait people, and so there is a code as well as the information about the care plan. So there's a report that is written as part of the ePCAM analysis that says these are the problems that were identified when we did our social determinants of health assessment. And then you just take that text, you paste it into the electronic health record, and then it goes as narrative. But we also were able to put in the actual codes for the problems, and those get communicated like other clinical problems like ICD-9s or whatever, and can be, so they are discrete data and they are communicated back to the Health Information Exchange through the clinical, the CCD, the quick continuity of care document.
Okay, thank you. So we have reached the end of our time for this webinar. Thank you all for attending. For those interested in obtaining continuing education credit for participating in this webinar, please visit the URL shown on this slide. You will have 14 days to claim your CE. The website will be available until October 3rd, 2019. After the website has closed, you will not be able to register your attendance and claim your CE credit. Upon exiting today's webinar, AHRQ is also fielding a brief evaluation, and we hope that you will be able to complete this survey to share your feedback with us. Thank you very much for participating in the webinar today, and we hope you all will join us for future learning opportunities. Thank you again.